always a pleasure talking about science right after lunch in a dimly lit room in a state that has a couple of hours different than the state I'm from, but hopefully we'll get through it just fine. So yeah, I'll be talking about adoptive immunotherapy utilizing chimeric antigen receptors, or CARs, today. I want to thank Dr. Cameron and those organizing for inviting me here. It's certainly a wonderful facility, and the breadth of perspectives in a unified disease entity is astounding. No conflicts of interest financially to disclose. So anyone know what this is a 3D pictograph of? No, not especially after lunch, right? So this is the rhinovirus. So this is the common cold. And this is just to compare with the disease entity that we're all fighting today, as well as in our careers, which is mesothelioma, which has a very poor prognosis. And the question is, the overarching question is, how is our immune system so capable of dealing with the common cold, but so incapable of dealing with cancer? And as alluded to earlier, a large umbrella problem is this idea of immune ignorance and tolerance, where even though you may have certain immune cells, well, first you have a large population of immune cells that doesn't recognize a cancer cell as a non-self cell or ignorant towards it, but you have immune cells that may initially recognize it as a non-self cell, but through multiple mechanisms become tolerant to it. And now we are geared towards understanding strategies to overcome immune ignorance and tolerance, and perhaps CAR T cells and T cell therapy is one way to do that. So as a background to immunotherapy, at the very crux of it, immunotherapy is any therapy that augments the host's or the patient's own immune system to increase its anti-tumor reactivity. And it's come in many different forms in cancer across the board. You can have non-specific strategies to do this. Some of those include delivery of cytokines, interleukins, and interferons, which were touched upon by Dr. Sturman earlier, to provide a general stimulus to the immune system to ramp it up. Immunomodulating drugs, some listed here, which are commonly used in practice for cancers like multiple myeloma, BCG for bladder cancer, and others that are used for skin disorders. The delivery of monoclonal antibodies. You can deliver antibodies towards the tumor cells themselves. You can actually formulate antibodies that target suppressive receptors on immune cells, immune checkpoint inhibitors, which we talked about a couple of times earlier. Tumor vaccination is another arm of immunotherapy, either in the form of prevention or treatment, and it can come in different formats: tumor cells, antigens derived from tumor cells, dendritic cells, or vector-based vaccination, or the category which I'll talk about today, which is cellular immunotherapy. We talked about dendritic cells in a fabulous talk earlier before lunch, natural killer cells, and today I'll talk about T cells. So the reason T cells are important have come from observations not only in mesothelioma, but also in lung cancer as well as other solid tumors, where you look at tumor samples. Here in this specific analysis was from mesothelioma patients after resection, and divide them into two different groups: those who have a high level of tumor-infiltrating lymphocytes, or TILs, in their tumor samples, or low. And you see that that divides them into different groups with statistically significant difference in survival. So this observation that's increasingly repeated, that an increased number of T cells in someone's tumor translates or is correlated with increased survival, underscores the importance that T cells are perhaps an important strategy of immunotherapy. And the basics of adoptive T cell immunotherapy is that you take a patient and you isolate their blood, and from that isolated blood, you use cellular isolation methods. Here you can use magnetic beads, you can use antibodies to draw out T cells, which is just one population of immune cells. And then within that population of immune cells, classically, you screen the immune cells, which have reactivity towards different proteins, and you isolate those that have reactivity perhaps towards the patient's tumor, those that are antigen specific. And you take that specific population and you generate them in large numbers outside the patient prior to reinfusing them back into the patient. So this summarizes decades of work, mostly pioneered by Dr. Steven Rosenberg at the surgical branch of the NCI, where he took tumor samples from patients with progressive melanoma, and then he was able to draw out large numbers of lymphocytes, tumor-infiltrating lymphocytes, and then screen them for reactivity towards candidate antigens in melanoma. And here you can see the example of the power of this therapy, where a patient who had progression, large burden in the posterior cervical area of melanoma, just 2 weeks after one dose of TIL therapy, the tumor was gone. However, as we've come to know over the past couple of decades, there's limited cancer types that respond. Growing them to the numbers needed prior to infusion can often be challenging technically. You also can see a wide variability of TIL infiltration among different cancers. So there's some report that thoracic malignancies like lung cancer, mesothelioma, the amount of T cells that can be found in those tumor samples can be as low as 10%. So if you start off with a very small population, getting them to multiply into a large population appropriate for dosing can be very technically challenging. Furthermore, only a portion of that small population may actually be useful for therapy. And that can be illustrated in a very simplistic way here. I asked my 9-year-old son, how do you see me picture a lung cancer or cancer of any sort? And he said, just draw the biggest circle you can. So that's what I did here. This is in no way meant to describe how homogeneous cancers can be, but if you were to just follow this and say that this large blue circle is a mesothelioma tumor, only a small population of all the cells in that tumor are tumor-infiltrating lymphocytes, or TILs. And it's not just this population that you're looking for, but even a smaller population, which are those TILs that have reactivity towards this large tumor. But it's an even smaller population within that small population that you want to find, which are those tumor-reactive TILs which are actually functioning. So TIL therapy for thoracic tumors has proven challenging. One, you have to identify this very small population, but you also have to expand them into a large population. And gene engineering may be a way to overcome some of these hurdles from a pragmatic point of view. First of all, surgery is not needed to isolate the TILs, right? That may not be as big of an issue in a cancer like melanoma, where some of the tumors may be easily accessible. For thoracic malignancies, it's not as easy, having to subject patients to more invasive procedures. You can engineer tumor reactivity, so instead of trying to find this specific population, perhaps take a larger population of T cells and then engineer them to now be tumor reactive. However, you still have the hurdles of having those T cells, after infusing the patient, successfully infiltrate the tumors and have preserved function to fight the tumor successfully. So if we were to go back to the schema in terms of the basics of adoptive T cell immunotherapy, really T cell engineering comes to play here at this step, where instead of trying to screen the T cells for baseline tumor reactivity, you are now taking TILs that are, or lymphocytes that are otherwise not reactive, and genetically modifying them to be reactive. So to summarize, transferring genetically engineered T cells, there are two main ways of genetically engineering them to be reactive to a tumor-associated antigen, or TAA. You can screen the TIL population for a specific clone of the T cell receptor, TCR, which I'll show in a graphic format in the next slide, and then clone that specific TCR into the rest of your T cell population. Or you can construct a chimeric antigen receptor, which I'll focus on today, or CAR, and deliver that through different genetic means into your T cells. So here's a T cell receptor, the basic structure of it. The main two domains of a T cell receptor are the alpha and the beta chain. The alpha and the beta chain, when it recognizes an antigen expressed in the context of an MHC class, signal the most basic of signals in the T cell being CD3 zeta, and that's what activates the T cell. This is an antibody, and antibodies that we've heard about before have the benefits of not requiring cells to work, but are highly specific and highly avid. And perhaps if you combine the high specificity and affinity of the antibody, probably one of the advantages of the innate immune system, combine it with one advantage of the adaptive immune system, and combine it to the chimeric antigen receptor, you start having a form of genetic engineering. Here you take the parts of the antibody which recognize a specific antigen, formulate it into what's called a single chain variable fragment, and then connect it with a transmembrane domain and signaling domains within a T cell. I just realized I used the same blue circle now to represent a T cell, whereas it was a tumor cell before. But anyway, you have the T cell receptor here, which you can clone in, or you have this chimeric antigen receptor, which you can clone into a T cell. So the signal 1, which is the basic signal of the T cell, the CD3 zeta, can activate the T cell, but through many years of work have demonstrated that it has limited efficacy because of two reasons. One is after the T cell becomes activated, it undergoes cell death. You want to have activity, but then you want to quiet down. And that's what the signal 1 has inherently in it, what's called activation-induced cell death. There's also been shown in patients limited persistence. The T cells don't last very long. They also don't proliferate to a great number. So after realizing that there are second signals inherent in the T cell signaling pathway, like CD28, which we talked about today, and others, an example which is 4-1BB, we're now having designer co-stimulation, providing a second signal, which has translated to enhanced efficacy, enhanced persistence and proliferation. We'll touch upon this a little bit later on, but if you have one signal, it's been termed a first-generation CAR, 2 signals, a second-generation CAR, 3 signals, a third-generation CAR. And though many people, including myself, would say more is better, not necessarily the case, as we've seen in case reports of patients being given the third-generation CAR who've undergone tragic death. So the target of choice, mesothelioma is perhaps an example, an ideal choice for CAR therapy, because you want an antigen that's highly or maybe solely expressed on tumor cells, but expressed at very low levels or not expressed at all on normal cells. Because a T cell, yet powerful, yet is not the most intelligent of cells. If you get provided a CAR receptor, it's going to target an antigen regardless of whether the antigen is expressed on tumors or not. But mesothelioma is perhaps a good example of an antigen where it's highly expressed on cancers like mesothelioma, which is of interest today, but other cancers as well, ovarian cancer and lung cancer, but is expressed at low levels normally in mesothelial cells of the pleura, peritoneum, and pericardium. There are some advantages of using CARs as well as disadvantages. So the advantages inherent to the antibody portion specifically is it's highly specific and binds with great affinity. You can come up with ways to augment the co-stimulation depending on which permutation you use. There's also MHC independence. Some disadvantages is that by and large can only target antigens on the surface of tumor cells. And a lot of clinical trials thus far have used non-human components, meaning that a lot of these antibodies, which the CARs are based off of, are based off of mouse anti-human antibodies. So there have been evidence in certain patients where they develop human anti-mouse antibodies, which may diminish the efficacy of your CAR. This is as opposed to the TCR engineering, which is nice because it relies on natural T cell signaling. It's not an artificial receptor. It can target both surface and intracellular antigens. But the disadvantage is that you can't design co-stimulation, so there's no inherent co-stimulation. There's also the potential of the two different chains which you put into the T cell to recombine with naturally occurring alpha and beta chains, which leads to T cell reactivity towards unexpected antigens. And because of the way T cells work through TCR, there's MHC restriction. So this has come to the forefront of scientific progress as well as the public eye because of reports like this, where groups out of Penn, led by Dr. Carl June, the NCI, the Baylor Group, and a group in New York City Memorial Sloan Kettering, where they've successfully targeted bloodborne cancers using CAR T cells targeting an antigen CD19. This is Emily Whitehead. She's the first patient to undergo T cell transfusion, and she's now 6 years out, in complete remission. So very effective response, very durable response. And here you can see an example. This is not from her, but this is an example of bone marrow aspirate from someone with follicular B-cell lymphoma that have high expression of markers of tumor as well as abnormal architecture. But then after just one infusion, 14 weeks later, you see normal architecture and absence of expression of these markers. And thus far, the summary of responses in treating CLL and ALL have been dramatic. 45% CR in CLL, 79% CR in ALL, and some of those remissions are years out from infusion. But if you look at the progress of CAR T cells as well as TCR T cells, as shown in this review from 2015, you can see that mesothelioma is mixed in with a small basket report on solid tumors. And if you certainly look at the number of protocols submitted to the RAC, looking at CAR T cell trials and TCR T cell trials from 2000 to 2014, you see a huge increase number of protocols submitted. So a lot of progress. But if you drill down into what makes up most of that progress has mostly been for targeting hematologic cancers, whereas mesothelioma is somewhere mixed in here. There have been a few reports about regarding patients being treated with CAR T cells. Two of those being directed against mesothelin from Penn, my institution, as well as Memorial Sloan Kettering. There's also a trial that's undergoing, not published yet, I believe, out in Zurich, where they're targeting stroma, targeting a protein expressed on fibroblasts surrounding mesothelioma. I'll talk about just briefly our results at Penn and then talk about some hurdles which we need to overcome to increase the success. So the first trial at Penn using mesothelin CAR T cells was led by Dr. Andrew Haas as a PI and the sponsor, Dr. Carl June. The first trial used multiple doses of the patient's own T cells that were engineered using mRNA electroporation. And the reason we used mRNA instead of usual approaches to change the genetic makeup of the T cells is because we wanted this receptor to be expressed temporarily. That was important because we wanted to first show safety. If a patient manifested early signs of toxicity with these T cells, you'd be fairly reassured that after a predictable amount of time, 6 days or so, the receptor would be downregulated, the T cells would be otherwise non-reactive, the patients would probably recover without any issues. So 7 patients were treated with multiple doses. In the second trial, after showing safety in this first trial, used 2 dose levels of now permanently expressing MesoCAR T cells. They were preconditioned with cyclophosphamide. I'll touch upon that a little later as to why that's the case. And 5 patients, not all with mesothelioma, but with cancers that express mesothelin, that included pancreatic and ovarian cancer as well in those trials. So in the first trial, using temporary CAR T cells targeting mesothelin, we were able to demonstrate transgene expression in the periphery, meaning you were able to detect T cells expressing your artificial receptor in the blood. However, only 1 patient had response, though fairly dramatic. Here you can see a CT section demonstrating large mediastinal tumor burden of the mesothelioma. And just after 3 months post-treatment, you see 50% volume reduction. But this is the exception to the case in this trial, as well as the next trial where permanently expressing CAR T cells were detected in the blood among a cohort of 4 patients. But again, there were no clear clinical responses seen. So unfortunately, the response in thoracic malignancies with mesothelioma being a good example is the exception, not the norm. And if I were to equate this or analogize this with a bedtime story, we're sort of like the tortoise trying to catch up with the hare, if you would analogize the hare with the progress made with T cells for liquid tumors. So the question is now, how do we get the tortoise boosted with engineered T cell therapy to catch up and perhaps surpass those who've had progress in blood-borne cancers? So what I'll do is I'll show a slide demonstrating some of the salient hurdles in solid tumor microenvironment, which I'm sure we'll talk about later, that present challenges to CAR T cell therapy in diseases like mesothelioma. So if you have this CAR T cell, as demonstrated by this blue circle, you have tumors here expressing their tumor antigen on the surface. The first hurdle is right after infusion in the periphery, right? The first hurdle is they need to properly traffic to the tumor site, to the bloodstream. Not only that, but as they approach the site of the tumor, they need to properly infiltrate the tumor, which may not always be easy because the tumor is not there by itself, but it may be surrounded by stroma, which is the case also in mesothelioma. But then you have other hurdles present themselves, like downregulation or loss of initially expressed antigen. Now these tumors become ignored by those T cells. Like I mentioned before, you can have stroma surrounding and protecting the tumor cells themselves, with one of the cells in the stroma being cancer-associated fibroblasts. You can have other immune cells that live in the same vicinity that suppress immune activity, like myeloid-derived suppressor cells or T regulatory cells. But those aren't the only hurdles that present themselves. You can also have immune checkpoint upregulation, which we talked about earlier. There's also metabolic derangements, like low pH, hypoxia, low nutrition, that the T cells must overcome. So certainly many hurdles, many of which may not necessarily be present when you're trying to target hematologic malignancies. I'm just going to touch upon two of these hurdles. Each of those hurdles could be an hour-long talk in and of itself. Because I only have 10 minutes, we'll talk about two different hurdles, one being trafficking, infiltration, and persistence, the other one being immune checkpoints. So before a lot of this research focus on the tumor microenvironment came to the forefront, we actually began augmenting at least persistence by the way we designed the CAR receptor. Soon after realizing that this signal 1 by itself was not enough to let the T cells last or proliferate to a very significant degree, the second generation and third generation CARs with additional co-stimulatory domains have proven themselves to at least increase in their persistence. So that's one avenue of augmentation. There's also what's called non-myeloablative lymphodepletion. Really the idea behind this is if in the bloodstream or if in the person, the amount of cytokines that are available to allow survival of immune cells, if it's limited, but you have all these endogenous immune cells that are not tumor reactive using up those same cytokines, now the T cells that you inject have to compete with those cells which are in the bloodstream for those same cytokines. So is there a way you can get rid of these endogenous T cells so that now you can create what's called space so that all of these cytokines, or most of them, are now available to the T cells that you inject? And that's what lymphodepletion does. And this results in expansion of those T cells which are transferred and are tumor reactive, and diminution of the numbers of those T cells which are non-reactive. So that's what's called eliminating cytokine sinks. There's also evidence that lymphodepletion, especially cyclophosphamide, can get rid of immunosuppressive cells like T regulatory cells. But there's also evidence that you can enhance antigen presentation through activation and availability of APCs. It's really the idea is to take this imbalance between the T cells which you inject and the T cells which are in the bloodstream and change that balance in terms of number and access to cytokines. And the agents usually used are fludarabine and cyclophosphamide. So the idea is have the patient provide T cells, and while the T cells are being prepared outside the body, prepare the patient by giving this cocktail of lymphodepletion so that the cells inside their body, which are not being modified, go down in number so that when you inject the T cells back in them, those T cells are at an advantage in terms of space and access to cytokines. So additional strategies, which many of these have not reached the bedside yet. So one is simply the idea, pragmatically speaking, of where to deliver those T cells. Can you bypass the hurdle of trafficking through the bloodstream if you deliver those T cells directly into the tumor or perhaps directly into the pleural space through a catheter versus through the bloodstream through an IV? And there is preclinical evidence demonstrating that there may be superiority in availability of T cells in the tumor sites if directed directly into the tumor. T cells are now being further genetically engineered to be cargo cells, where those cytokines which are limited in number in the bloodstream now can be produced by the T cells which you inject. So instead of depending on, in this case, IL-12 levels that are available in the person's body, you now genetically engineer a T cell not to only have redirection toward the tumor with their CAR, but now it produces itself the cytokine it relies on to proliferate. Early in my postdoc training, another way we tried to enhance trafficking was by looking at the different types of chemokines that mesothelioma cells made. So we screened a bunch of mesothelioma cell lines, but also screened pleural samples from mesothelioma patients and asked, are there certain chemokines that are produced in large amounts that T cells cannot react to them because they don't have the appropriate chemokine receptor? So lo and behold, one chemokine stood out, which was MCP1. It stands for monocyte chemoattracting protein 1, which is usually meant to attract monocytes, not T cells. And you'll see not only in our study, but in many other studies that MCP1 is secreted in large amounts by different mesothelioma samples. But when we looked and screened our T cell lines, either pre-post activation, pre and post CAR engineering, there were very, very low levels of the appropriate chemokine receptor, CCR2. So then what we said was, can we engineer the CAR T cell to now express the chemokine receptor, CCR2, so we can allow them to traffic better? And that's exactly what we did. So what we saw was in this model of a mouse model that's implanted in the side with a human mesothelioma cell line grown to a very large size, 200 to 300 millimeters, that are injected with either nothing or non-transduced human T cells or human T cells with our CAR, or human T cells with both our CAR and our chemokine receptor, you should now start seeing a dramatic increase in the amount of tumor control after just one dose of T cells. And here we can see that if you look inside the tumor, there's many more T cells in the tumor. And just to show that this wasn't a general expansion of T cells inside the mice, we also looked at the blood at 5 days and show that the number of T cells that had both transgenes were lower in the blood but higher in the tumor. So perhaps one way of enhancing trafficking. So I'll end the talk with the 5 minutes remaining regarding immune checkpoints. So this is obviously a topic that's very hot. All clinicians and scientists, as well as our cousins and sisters, know about immune checkpoints, right? And the one that's come to the forefront is, or one of them is PD-1, PD-L1, and it's in its pathway of inhibition in T cells. So it works in the context of T cell receptor engagement. After initial activation of the T cell through the TCR, you now have, if there's co-stimulation absent, inhibitory signals. Here the example is PD-1. So if I were to go back to this very simplistic diagram where I highlighted that trying to obtain this population of TILs that are tumor reactive at baseline but also functioning properly is very small. If you now look at those tumor reactive TILs that are hypofunctional specifically from PD-1 signaling, that population perhaps is even smaller. And this is probably, in my mind, the biggest reason why only 20 to 30% of patients who undergo PD-1 therapy respond, because many patients who get PD-1 checkpoint blockade, that population is either non-existent or very small in number, or perhaps hypofunctional because of other reasons other than PD-1. So the question was, could the combination of CAR or perhaps TCR engineered T cells and checkpoint blockade together lead to a greater response in solid tumors than either alone? With the rationale being that small population of T cells that I highlighted earlier, could you expand that population by transferring in those T cells? But if those T cells undergo hypofunction because of PD-1, now you introduce checkpoint blockade to increase that response rate from 20 to 30% to even higher. So really the question was, could the blockade of PD-1 and other inhibitory receptors augment the success of our transfer T cells in solid tumors? And this was demonstrated in 2 different papers, one in a model of human mesothelioma and another in a model of human lung cancer, where in both cases, mice that had either mesothelioma or lung cancer flank tumors were given 1 dose of engineered T cells. You were able to see slowing of tumor growth, but when we isolated those T cells from the flank tumors, they were all suppressed in function. When we looked at reasons why they're suppressed, they all had high upregulation of PD-1 at the end of the experiment. So we went back and repeated the experiment and demonstrated that blocking PD-1 in combination could augment the effect. So here's another way where we try to interfere with PD-1 inhibition, and this is the final part of my talk. So could we do it by further genetic modification? Instead of just combining with PD-1 antibody, is there a cool way in which we could modify it further so that we can take that inhibitory signal and turn it into an activating signal for the T cell? And that's exactly what we did. So we know the structure of PD-1 as it naturally exists. There's an extracellular domain that binds to PD-L1. This is the T cell here. And it signals through very well-characterized tyrosine-based inhibitory and switch motifs. What we did was we sequenced the extracellular domain, but instead it fused it with one of the co-stimulatory domains of the T cell itself. So here, presumably, if you had the switch receptor bind to the ligand, PD-L1, instead of inhibiting the T cell, it would now activate it. I went backwards. So we repeated the experiment again in a mouse model of mesothelioma flank tumors, and they were divided up randomly into either non-treated or treated with 1 dose of T cells that had no tumor activity, or T cells that were combined with antibody. And this antibody actually is pembrolizumab from the pharmacy, where they were, the antibody was given at 10 mg per kg, the usual dose you'll see in clinical trials, to the mice every 5 days. You don't see an effect by itself. If you combine our CAR T cells directed against mesothelium, you see our usual slowing of tumor, as demarcated by this line with squares. If you provide antibody in combination with CAR T cells, pembrolizumab, you see a augmentation of control, statistically significant but modest at best. But now, if you have T cells given at one dose that have both the CAR as well as this new PD-1 switch receptor, you now start seeing cures and regression. There are potential advantages of blocking PD-1 using the genetic modification method rather than combining with antibody blockade. Perhaps you could have decreased toxicity, right? Instead of systemically blocking PD-1 or interfering with it and having toxic effects manifest, if you have PD-1 blocked only in the vicinity of the immunosuppressive tumor microenvironment, could you avoid some of those toxic effects? You also avoid interfering with PD-1 signaling in otherwise non-tumor reactive T cells. Furthermore, as I alluded to earlier, where you want the highly activated signaling of third-generation CARs, but you want to avoid the toxicity that's been shown with using third-generation CARs in patients. This provides you with a way to have second-generation CARs transferred into patients, but then being converted into a third-generation signal only in the context of the tumor microenvironment that expresses PD-L1. So in summary, engineered T cells have demonstrated profound success in liquid tumors. I don't think anybody can argue with that. They do hold promise for treatment of solid tumors like mesothelioma and lung cancer as well, but certainly there are a significant number of hurdles, some of which I've highlighted today, that are associated with the solid tumor microenvironment. The two that I've highlighted are trafficking, infiltration, persistence, and inhibitory receptors like PD-1. And really, a lot of my bets are placed in future development and the idea of combining the provision of T cells that are tumor reactive to amp up that small population with blockade and inhibitory receptors, which we know is one significant hurdle once the T cells make it into the tumor and try to fight it. So with that being said, I want to thank individuals in my lab as well as my mentors who've helped train me and allowed me to present some of the experiments today. Dr. Albelda, Dr. June, my co-mentor, our thoracic surgeon, provide some of the human samples as well as some of the funding sources. Thank you very much.